So my name's Dr. Quinn. I'm VP for Educational Resources for Medic Mentor. I hope many of you have joined us for many of the previous study guide webinars. This is the webinar for our March 2019 study guide. Now, I'm going to cover the medical components, and then my colleagues, Dr. Uppal and Dr. Pegg, will cover the dental and veterinary components straight after this one. So I hope by now you're quite used to the study guide series. You'll know that there is a problem-based learning case. So this basically PBL is used in most professional courses, very commonly used in medical school courses as well, and it's a really good way to learn actually, because it presents a diverse range of information and which you can pick up on what interests you the most. So typically in medical school, you would pick up on something that interests you, go away, work as a group, look into it in more detail, and then come back and present your learnings and findings to the rest of the group. So it's a very very good way of learning and pursuing what interests you. So let's start off with the problem-based learning case for this March study guide. So this was all about Ebola. Now, Ebola, I'm sure many of you were aware of the outbreak, which ran principally from 2013 to 2016. It was essentially an endemic. It wasn't quite a pandemic, fortunately. But in this case, it was basically a medical student who was going away on her medical elective to Guinea. And unfortunately, there was an Ebola outbreak while she was out there. So I'm sure you've all got the questions. By all means, if you have any questions as we go along, just put them in the box on the side and I'm happy to answer them. So here we go. So the first question was about the vaccinations that Samira received. Now, the question about where you can find what vaccinations you need is on the Centre for Disease and Control of Diseases and Prevention website. So it's the CDC website. So you can type in any country that you might be visiting and then work out what vaccinations you're going to need before you visit that country. So it's very specific. It all depends on what pathology and infections are endemic to that region. Endemic means there's a persistent infectious burden. So, for example, malaria is endemic to certain countries. So if you visit those countries, you need to be vaccinated. Not in the case of malaria, you have prophylaxis, but that's just an example. So the first question was about the vaccination. So one of the first vaccines she received was all about hepatitis A. Now, hepatitis A is principally a fecal-orally transmitted disease, which affects the liver, essentially, leads to hepatitis. Itis, in any word, means inflammation, and hep means regarding the liver. So hepatitis is an inflammatory response of the liver. Hepatitis A is a specific virus. It's an RNA virus that infects the liver. So principally, patients present with, it's usually quite mild, a mild infection. They might get a bit of nausea, abdominal pain, so tummy pain, vomiting. However, in very rare cases, it can be more severe and lead to complete liver failure, but that's not the norm. You can also become jaundice. Now, jaundice basically arises because of bilirubin building up in the blood, which normally is released in your urinary and your fecal systems. So if the liver it's the liver that processes your bilirubin. Bilirubin is a waste product of red blood cells breaking down. So if the liver isn't working properly as its metabolic organ that it is, it gets rid of toxins, it processes drugs, it gets them out of the body, basically. If the liver stops functioning, then you start to build up toxins in the blood. So bilirubin is a good example. and then you become yellow. So if you type into Google a yellow patient, the first thing that goes yellow is often, you can see it very clearly in the sclera, the white of the eyes, but you can also see it in the skin. And some people are very obviously jaundiced, which is a sign that they have a very significant elevated bilirubin in their blood. So hepatitis A is one of the hepatitis infections. It's the most common infection that is preventable, so i.e. can be vaccinated against. So obviously you could put it into CDC, your country of origin, and see if they recommend a hepatitis A infection. Now, as I was saying, most cases of hepatitis A are very mild. If it is severe, it's much more likely to be in older people. They're likely to have more symptoms, and age is a big factor in it. But there is no risk of chronic liver disease with hepatitis A. It has a very, very good prognosis. By prognosis, we mean overall outcome for the patient. So it's a horrible infection that will come and it will go over a period of usually a few weeks. Okay, now the other vaccine that she received treatment for was hepatitis B. Now, hepatitis B is one of the most frequent the most frequent hepatitis infection worldwide. Its transmission is usually what we call transmitted via either sexual intercourse or IV drug use. So it's very common in a specific subset of individuals who usually with lower socioeconomic status. So in those patients, you do have to be more aware that hepatitis B is a risk to them, and therefore more actively seeking it out, because you need to seek out hepatitis B infection early, because how it differs from hepatitis A is hepatitis B does carry a risk of causing chronic liver disease. So chronic hepatitis B, for example, can lead to fibrosis of the liver, which is essentially scarring of the liver. Now, the liver actually has a very good regenerative capacity. So you can sort of lose up to 70% of your liver function, and the liver will just regenerate itself. It's a hugely metabolic organ. However, if it becomes damaged because of a chronic infection like hepatitis B can be, it becomes scarred. It then becomes like cirrhosed and abnormal, sclerotic, and basically the cells aren't working in the way they should be, and that then leads to a risk of developing a cancer, so carcinoma or hepatocellular carcinoma. Which is cancerous and obviously very, very poor prognosis. So that's how hepatitis B differs. Now, hepatitis B, we talked about where it's endemic to, specifically South Asia and Sub-Saharan Africa are very well quoted places. It has a slightly longer incubation period than hepatitis A. What we mean by that is how long it takes for that pathogen to build up in the blood system before it starts to present as an infection. So it's usually 69 to 90 days for hepatitis B. Now, in terms of how you detect hepatitis B, you can look at viral load and what we call HBV genotype and serology. But you also look at antigens and antibodies. So I'm sure you've been learning about this in your A-level or even perhaps GCSE work. Antigens are what your cells express, they're the markers. Your antibodies are what your immune system produces, which binds to antigens, like a lock and a key. And when an antibody binds to an antigen, it's usually marking it as an abnormal substance, a pathogen, something that's gonna cause a problem, basically. So you look at both of them in hepatitis B. So you have some antigens in the blood that might indicate a person has had a past infection. You might have some antibodies that reflect that it's more an acute infection or that they might still be infectious. But also remember what we're talking about. We're talking about vaccinations, and hepatitis B is something you can be vaccinated against. So you can also have antibodies in your blood, not because you've ever been exposed to hepatitis B, but because you've been successfully vaccinated against it, and therefore you can't get it moving forward. So I've just got a question here. I have a question. Why do some drugs have indications alongside them to not consume grapefruit juice? Oh, that's a really good question. So that is all to do with your liver metabolism, and it's the principal metabolic system is the CYP450 system, which is a degradation system for drugs, basically. Now, there are certain chemicals or drugs that activate that system, make it more active, so the enzymes work over time. But there are also some chemicals and drugs that decrease the activity of that system, making it work less effectively. And that affects how drugs are processed, basically. And you would be surprised, warfarin is a very good example. And of a drug that has a lot of interactions, a lot of chemicals that will affect how it's processed and therefore affect its effectiveness and its activity. So that's a really good question, but it's very common. And the classic example with grapefruit is usually with statins. So it's a very good question. Okay. So then we've covered hepatitis A, we've covered hepatitis B. I just wanted to touch on cholera and yellow fever as well. So cholera is basically acquired because of fecally contaminated water. So fortunately in the UK, it's not a widespread issue. We see very few cases annually, and it's usually brought in from abroad. Cholera essentially results in a very watery diarrhea, which might sound like not too significant, but actually it is. It can lead to very profound dehydration and even death. And it remains a problem usually in developing countries. Now, in most cases of cholera, it's actually asymptomatic, so you actually don't get any symptoms with it as such, and you might just be infectious and carrying it without being aware. However, in the remainder, you have this profuse diarrhea. It actually requires a very high organism load, bacterial load, to actually cause symptoms. And your only real treatment, you can't really, you can give oral rehydration salts, but she was also advised to be vaccinated against it. And then the final one she was vaccinated against was yellow fever. Now, yellow fever is, as it says on the tin, it causes jaundice, which you've already talked about. It's transmitted by mosquitoes. So basically, the virus will sit in mosquitoes' stomachs. It will then be transmitted to the salivary glands of the mosquito. So then when the mosquito bites the individual, you're getting this transmission, essentially. Again, it's very common in sub-Saharan Africa and South America. There are a fair few cases per year and a significant number of deaths, so about 30,000 deaths in a year. But thankfully, in the UK, for example, there have only been 6 cases since 1996. And of those 6 cases, none of them had been vaccinated. So this is why you should be vaccinated against something like yellow fever. Now, yellow fever is one of the infectious diseases that can induce a viral hemorrhagic fever. This is essentially where, because of the virus in your blood, it's initiating such a massive, profound inflammatory response, massive release of cytokines, which are your immune system's messengers, signaling that there's a problem, that there's a pathogen, for example, and then basically leads to shock. Your body like reacts to that very badly, and you go into a profound sort of hypotension, poor blood supply, and multi-organ failure because of it. So it can be very severe and fatal, as we've said. So principally, again, your management is supportive. So I've described some quite scary diseases, hepatitis B, cholera, yellow fever. So it's why it's so important to be vaccinated and to make sure that you're getting the right vaccinations before you travel. Now, some of these vaccinations do take time to build up the immunogenicity. So therefore, it requires a lot of planning before going on a trip. And it can be, you should be looking anywhere you're going in the world, what's endemic, what vaccinations you need. So it's very important. Now the other question I raised was about malaria. Okay, so malaria there are two main sort of groups of malaria. It can be very severe disease, which is caused by Plasmodium falciparum, which essentially presents much earlier, so presents within about 1 to 6 months of the malaria, of being bitten and being infected. And then you've got sort of less severe forms of malaria, which can actually present anything from months to years after initially being infected. So those are the Vivax, the Ovale, and the Malariae. Okay, so the process, what happens is you're bitten by a mosquito, which has like sporozoites and eggs and has basically the infection in its saliva that goes into your blood. It then gets transmitted to the liver. They mature and then release the organisms. Okay. Now it's very common in the tropics and the subtropics. That is where malaria is endemic to. And in terms of actually diagnosing malaria, the gold standard is still to do a blood film and a blood smear, thick and thin. It needs to be specifically. Now there are other newer techniques for diagnosing malaria, but it is very important to get a blood film, and often you need to have multiple blood films because even though it's negative doesn't mean they definitely don't have malaria. Now, in clinical practice, it's actually very difficult to diagnose malaria because it's often such sort of non-specific symptoms, and you really have to be thinking outside the box when you're coming to diagnose it. So patients might present with things like weight loss, muscle aches and pains, tummy pain, sickness. It can really be anything they can present with malaria. But you need to think, have they been to a country where malaria is endemic, particularly in perhaps the last year or so, or even beyond that, so quite a long while back. Now, if it's a non-falciparum malaria, i.e. the less sort of severe form of malaria, it's usually treated with chloroquine. However, if it's the most severe form of malaria, the falciparum malaria form, then it's quite a complicated treatment regime. It's prolonged. They're going to need to be, under the specialist care of an infectious diseases unit consultant, because there is a risk of mortality burden with malaria. So you need to make sure they're under specialist care and as an inpatient. Otherwise, it may be able to be managed in an outpatient setting. Now, as with all of these infections, the previous infections we were talking about, hepatitis, yellow fever, cholera, vaccination is your preventative agent, basically. With malaria, you can take prophylaxis to prevent it. But it's not just chemical prophylaxis. It's not just drugs that are important. The other factor that's important is, basic behavior and safety. So using insecticide nets, perhaps wearing long sleeve shirts in hot countries, not doing too much outdoor activity after sunset, because that's often when the risk can be highest. So its basic preventative techniques are the trick, and the NHS is all about prevention is better than cure. Okay, so that was the malaria. So you can see in the case given, she had the malaria prophylaxis. Now, it's probably important to say to you that malaria prophylaxis is actually pretty horrible. There are a lot of side effects with it. You can find them all in the BNF, British National Formulary. But it's the price you pay, and you often, depending on the prophylaxis, you might need to start it a few days or a few weeks before going out there, and perhaps even continue it beyond your stay. And that's what people aren't very good at, which puts them at risk of developing malaria. Okay. All right. Now, one I've just noticed there's another question as well. So I have a question too. It seems that many medical terms can be broken up and then translated back into their meaning. What are some basic broken up words like hypo, hyper, etc.? Okay. Yeah. So a lot of medical terms are um, often come from like the Latin basis, is one thing, and I'm just you feel like a bit on the spot. I'm just trying to think um, of some examples. I'm not doing very well. Let me think about it, and I could perhaps like give you like a bit of a dictionary next time about some common terms. You're right, though. I mean, in the past, a lot of medical diseases and conditions were named after the people who first recognized those conditions. So, for example, today I saw a patient. I'm a stroke doctor at the moment, a junior doctor working in stroke medicine. And we saw a man who'd been discharged with a recent subarachnoid hemorrhage. So, basically, a bleed on the brain, discharged a few days ago, came back in today with seizure activity. And specifically, it was a Jacksonian march. Now, that is named after the professor or the doctor who first recognized this phenomenon of seizure activity. But that was historically how a lot of medical conditions have been named. However, we're trying to move away from that now, because often it's not helpful to, remember it by a person's name. It's very abstract. And often when you're naming after someone's name, there's very specific entities that have to be fulfilled, whereas it's usually more helpful to say exactly what it is. So, for example, hepatitis, infection of the liver. Cholecystitis is infection of the gallbladder. Anything that ends in itis is inflammation. So I will certainly, I'm really sorry, I blank on the spot. I can't really think of any examples, but I will. It was something I will put into the next webinar for you, definitely. Okay, so one of the other questions was about health tourism. Now, this case did raise quite a few ethical questions in it. Now, health tourism is the idea that basically westernized medical students and potentially even doctors, but more focusing on medical students, go and get experiences abroad where they're in very resource limited settings. And because of the lack of staff, the lack of resources, and the lack of specialist expertise, these individuals who aren't doctors are asked to step up to the mark, or asked to, oh, you've got 2 years of medical training. Why don't you be our doctor for the day? Or, why don't you just do this, or just do this operation, or assist us with this procedure? So there was this case where people were going abroad to get experiences in procedures and surgery that would never happen in Western modern medicine, because the principle is you should be safely trained, competent in any procedure, particularly the more invasive procedures, before you even think about carrying them out. So it's the ethics around, is it right for people who are very resource limited, have no access to healthcare, that somebody who isn't fully trained, isn't a qualified doctor, should be providing a service of care? And it's a point for discussion. I think on a very personal note, think it's very difficult. I would find it difficult being in that position, because how can you say no in a setting like that, where everyone chips in, everyone's just doing their best with the resources that are available? but I think it's certainly something to be aware of as a prospective medical student or veterinary dental student, because there are organisations that might allow you opportunities for health tourism, and just be aware about the ethics of it and what you're signing up to is what I would advise you. Now, the question around epidemics and pandemics. An epidemic is basically an outbreak of a disease that affects people in a sort of a country or a community or neighbouring communities, which is basically what happened with Ebola. Pandemic is when an epidemic starts to spread throughout the world. Now, infection control is actually becoming more and more of a risk because of the spread of travel, how easy it is to get a flight from one corner of the world to the next. All the time we are spreading infections. It's very recognized phenomenon that athletes, we're talking like Olympic athletes, when they travel to the destination where they're competing, but on the plane there is a lot of risk, and they often become unwell when they arrive, with chest infections and viral infections, because of that spread and because they're immunosuppressed because of their high athletic status. So it's really happening. It is a massive risk, and it because of spread of humans and how easy it is compared to how it was many hundreds of years ago. So those were basically the differences between epidemic and pandemic. Okay, so now I just wanted to touch on Ebola. Now I'm not an expert on Ebola. It's something that I found really interesting. It's never something that was covered in medical school for me, but I think it's a very effective pathogen, essentially, in the worst possible way. Now, it's an RNA virus, and it essentially works by systemic replication, and it suppresses the immune system. It leads to a highly abnormal inflammatory response, I guess a bit likened to like the viral hemorrhagic fever. It leads to major fluid losses. So again, profound diarrhea, profound dehydration and nausea, and it carries a very high mortality. So from a pathogen perspective, it's a very successful pathogen, but very, very bad for humans, obviously. Now, it's affected principally, it was Guinea and Sierra Leone and Liberia were the main countries affected by the Ebola crisis, which ran over about 3 or 4 years, 2013 to 2016. Now, Ebola is zoonotic, and what we mean by that is it's actually an infection of usually bats and other animals, but it can be transferred to humans. So it has enough viral pathogenicity to be transferred to work on multiple species, and it can also be spread between humans. So, for example, contact with either bodily fluids or people who've passed away because of Ebola, and there's even reported a sexual transmission of Ebola as well. So there's multiple routes for transmission. Now, Ebola was, I think it was, it's something I really wanted to talk about in this case because it was a massive demonstration of sort of our global response to such a profound outbreak. Now, the United Nations were involved, the WHO involved, which is an NGO for global health, essentially. It has about 7,000 employees, but in an infectious response like that mounted by Ebola, it was actually a lot of volunteers as well. Not obviously medics and specialist doctors in infectious diseases who travelled out there to try and contain the situation. Now, one of the biggest challenges was obviously, as I'm sure you're aware, that our Western culture is very different from other African cultures, and we're different people, different heritages. So what was actually a big problem, which I spoke about in the case, was when for people in those communities, they wanted to bury their loved ones who had passed away. They wanted to perform their own religious ceremonies that they would normally do in any case. The problem was any contact with corpses who were infected with Ebola put all of those individuals at massive risk, which again put further people at risk. So they tried to do a lot of education, and obviously there's language barriers, cultural barriers. There was a lot of animosity initially between the communities and between like the professionals involved in the Ebola response from the UN and the WHO, and it was thought to have contributed to further spread of Ebola and worsening of the increase in the number of cases, which amounted to about 11,000 deaths. But I think it just shows the importance of consideration of community, of people, and how environment affects health and disease. And it shouldn't be underestimated. And you really have to take that into account with any infectious diseases response that you're putting in place. Now, with Ebola, the way it was diagnosed was essentially real-time PCR. So I'm sure you've learned about this in your studies, but you're basically you increase the DNA or the RNA available, so you mass produce it, and then you you genetically examine it basically for certain genotypes. To diagnose Ebola, so that they managed to bring that over in the response. They also, as part of the response, managed to bring in point of care biochemistry testing. Now, if any of you went into hospital, went into A&E, one of the most basic things you would have is a blood test. So you would have a full blood count. So you'd have your red blood cells, your white blood cells tested, your platelets, your neutrophils. You're looking for signs of infection or anemia. But you'd also have what we call urea and electrolytes tested. So you look at renal function, determined by urea and creatinine, and then you look at your electrolytes, sodium and potassium principally. Now, can you can't imagine it in some developing countries. You don't have a pathology lab. You can't get bloods to a lab quickly for processing. You don't have the manpower to be able to do it. So they actually brought in this point of care testing just to determine how sick people were. And we are so reliant, I think, in the West on it's not just the patient in front of us, but it's all the investigations we do. And it's a very different type of medicine in under-resourced, underfunded healthcare systems. So that was a big factor in the Ebola response, was determining those who were really sick and needed more attention, compared to there were some people with Ebola who were asymptomatic, and there are some survivors from Ebola as well. There are some people who have the immune system to be able to tolerate it. So they needed to discriminate that very, very quickly and easily. Now, the other very interesting point about the Ebola response was, obviously, it was over a 3-year period. And it was during that period that the WHO actually recommended and sort of repurposed drugs, previous antiviral drugs, for usage in an Ebola setting. Now, this is worlds apart from our Western clinical practice. For any drug to be given to a human being in day-to-day practice, it usually has a 15-year period where it may have been tested in the laboratory. It's often tested on animal testing. It's then brought into healthy volunteers, so you're sort of moving into your phase 1 trials, then into subjects, so humans with that disease, a very small number. You're looking at safety, dosing, effectiveness, adverse events, and only after a 15 to 20-year period, sometimes even longer, is it then rolled out into mainstream practice. Now, can you imagine, in an Ebola crisis, you do not have 20 years to play with, and therefore the WHO made this decision to allow drugs previously indicated for other purposes to be trialed in patients with Ebola on for essentially either as emergency treatment when nothing else was available, or on a compassionate use basis. Now, the ethics around that are a different story. Obviously, tragic times require tragic circumstances, but I think it's fascinating, and since the Ebola response, there's actually been a massive amount of research into Ebola. It's really sort of pivoted it and made us aware that how would we deal with an even bigger pandemic than Ebola? Something that really could wipe out humans. It's infection is a massive global threat. How are we going to deal with that? And there's been so many lessons learned from the Ebola crisis and Ebola response. And they've done a lot of work and research actually talking to Ebola survivors, asking them what was the experience, how were you treated, how did it make you feel, what were the problems with our response, how can we improve education and communication, which is hugely valuable for the future. And I think as humans we always think we're infallible, but you always have to be aware of threats such as this. So it's an incredible it is an incredible story when you look into it and look into how it was managed and how we have managed to contain it. We are no longer in an Ebola outbreak. There are still communities affected by Ebola, and it is because you've got sort of there's different strains and of the virus and different versions of it, which are still endemic. But thankfully, it is something that is now contained. And unfortunately, in our case, our medical student went home safely. It's entirely made up case that I described, but it's an interesting one. In terms of principles of infection control, that was another question I gave. Now, infection control is pivotal in hospitals. Now, essentially, I can see a few questions as well. I will come back to those. So, infection control. So basically, you must have all heard of MRSA and multi-resistant, drug-resistant Staphylococcus aureus. There are, other very widespread infections like carbapenem-resistant organisms, ESBLs, extended spectrum beta-lactamases. These are all multi-drug resistant bacteria, and that becomes a problem because bacteria that are resistant to an array of antibiotics then mean it can cause an overwhelming infection that can't be treated. And antibiotic resistance is actually it's thought to be one of the biggest risks to human health and global health as well. And it's partly because of poor antibiotic stewardship. So what we mean by that is, over prescribing antibiotics, and not just over prescribing it where it's not indicated, but then also compliance with antibiotic therapies, because essentially antibiotics work if you've got a bulk of bacteria. Once you've had some antibiotic, it starts to get rid of, say, 90% of the bacteria, but you've then got 10% of the bacteria that are still hanging on in there. So you need to give a little bit more antibiotic in order to get rid of that, I don't know, another 9% of the bacteria, but then you've still got 1% of the bacteria remaining. And that is why you need to give a complete course of antibiotics and not just give it, ad hoc or an incomplete course, because what will happen is you will be left with bacteria that then continue to replicate, become a problem all over again, and might build up resistance to that antibiotic because you're giving them that opportunity. So it's not just in healthcare that there's poor stewardship. We use antibiotics often in crops and pesticides, and in agriculture, antibiotics are widely used. Even in veterinary medicine, as I'm sure Dr. Pegg will tell you, antibiotics are widely used, and the more we expose our environment to antibiotics, the more opportunity that we're giving to build up this resistance. So it's a very significant threat to humanity, and there is ongoing work not only to develop new antibiotics but also to identify alternatives to antibiotic therapy, and it's very topical in the microbiology frameworks. So, in terms of your principles of infection control, you were trying to prevent these multi-drug resistant bacteria from spreading from person to person. And MRSA is a really good example. You will swab everybody who comes through the door of a hospital, and if they're demonstrated to carry MRSA as a native carrier, they're then given a treatment course to eradicate it so that they're not spreading it to other people. But it's not just about humans, carrying the infection. It's also equipment. Imagine in a hospital, all of the equipment, that patients are in contact with, doctors are in contact with, it's all at risk of becoming contaminated. So, every time a doctor comes to see a patient, they have to alcohol ethanol swab their hands. That will basically kill uh, organisms, provided that there's no contact with bodily fluids. If you have any contact with bodily fluids, so blood, urine, anything, you need to wash your hands properly, because that's the only way you're going to be able to get rid of those pathogens. It's not just contacting the patient we need to be aware of, it's contacting their surroundings, their curtain, their bed, their furniture. When we examine them, we need to be aware that we are potentially transmitting bugs from that patient to another patient when we go and examine them. So it's really, it's very important to be aware of that and try and prevent that. And as I've said, you have to be aware of portal of exits of bacteria and pathogens. It might be secretions, it might be feces, it might be urine, it might be saliva. Whatever it is, it might be, for example, TB patients, where TB is usually a lung infection, where the TB bacteria and is released by droplets in coughing, so in secretions. So if with TB patients, they need to be isolated in a side room, so they need to have a room of their own, and ventilation as well, stopping that TB from coming out of the room. So that's another means of infection control in the hospital. And it's not just about the patients and the staff, it's also about members of the public. And I'm sure you've all seen signs asking relatives and carers and loved ones to stay away from the hospital if they're infectious. If they've had nausea, vomiting, diarrhea for the last few days, they need to stay away, because when they're coming into hospital, they're coming into contact with vulnerable people, the immunocompromised, the very young, the elderly, people with chronic diseases that are much more at risk of infection. So it's about what's coming into the hospital as well, and making sure you're controlling that. So you can see how challenging infection control is on a day-to-day basis. It's incredibly challenging, but it's something we do our best with, and it's something to be very mindful of, even as a medical student, and when you're shadowing as well in your hospital placements, dentistry placements, veterinary placements. Make sure that you are thinking about, am I spreading any infection here? Have I had contact with bodily fluids or equivalent? Do I need to be washing my hands? What can I do to try and make sure these sick people aren't at any increased risk? It's so important. Okay, now I'm slightly conscious of time. Now, there's two more bits I wanted to cover. One of them was other factors that determine health, and then the other thing I'm going to cover is about the ethical case scenario. Now, so the last bit for the PBL case. Now, if you just think about all of the factors that determine health, you could probably be there all day in reality. It's not just what makes you you. It's not just partly your genetics, your age, your gender, your hereditary factors. It's your lifestyle. Are you physically active or not? Are you are you a healthy weight? Are you all of these factors determine your health, your well-being, your risk of disease and infection. But it's not just about you, it's about the community you're within as well. Are you do you live with good sanitary conditions? And vast majority of people in the UK thankfully do. But imagine elsewhere across the world that's not the case. If there's 20 people living in a small room, imagine the spread of disease and infection in that setting. And think about other factors like your access to healthcare will determine your health. Can you just walk down to your GP that day if you're not very well, or do you need to trek, I don't know, 100 miles across the country walking, to get to a local healthcare provider? um, Unemployment as well. Do you, is Thankfully in the UK, NHS is free at the point of delivery. Imagine in America, every time you present to a doctor, you need to give some money, you need to hand over a card. So imagine how that would affect your health and access to health as well. What are your living and working conditions like? What's your education level like? All of the people I'm speaking to on this webinar, you're very well educated. You're looking for a career in medicine. You know about science. You understand about health and disease and the factors that determine it. You understand the immunology, the biochemistry, biology, chemistry. Imagine if you don't have that level of intellect, how can you possibly comprehend either a complicated cancer or a complicated infection and what that means to you? And then it's other things. Like I was talking about earlier, it's your culture. What does your culture view on health? There's a lot of cultures that don't accept mental health as an illness. They don't recognize it. They don't allow people to talk about it. And even in Western culture, for many years, this has been the case. I think thankfully about time we're starting to get better at discussing mental health problems and recognizing that as much as anything, it is a problem with your health. It is a not so much a disease, but it's something that's affecting your ability to function like any physical health condition would. And therefore it's not all in your head. It's not just a mental entity. It's actually a lot more than that. And I think we're certainly getting better at realizing that. So, all of these factors are things, even in medical school, dental school, you will cover all of them, because when you're reviewing a patient, you're not, no person is the same. No person with a condition is the same. You need to take into account their lifestyle and their community when you're giving advice to them that's going to be of benefit to them and potentially even their community. So it's an important one to think about. So that completes everything I wanted to do about the PBL case. Now I can see a few questions here. And Robbie's answered about my the CYP450. Excellent. Thank you, Robbie. Robbie's one of our mentor medical student scholars. He's a fantastic ambassador for us at Medic Mentor. So it's great to have you on board, Robbie. Do you have a double jointed thumb? Oh, not that I'm aware of. No, I don't think so. No. Maybe it just looks weird on screen. Anyway, right. Let's finish my medical component of the talk. The final thing I wanted to go into was just about the ethics. Okay, the ethics of this case. So this was a 13-year-old girl who started a new relationship. She's come to her GP specifically asking about contraceptive options. She's not ready to have a family, but she is starting to think about sexual intercourse. Her boyfriend is 13 years old, and she's come to talk to you as a GP today about contraceptive methods to prevent pregnancy. Now, I'm going to start doing this ethical case each week to try and get you into the habit of thinking about ethics in the context of clinical practice. So what I wanted to particularly focus on in this case is around consent, and also consent for young people, i.e., generally younger than 16 years old. Now, for any adult, okay, so 18 and above, we assume that they are competent to give consent. So, i.e., they're competent to make a medical decision. And if you imagine your parents, they have the intelligence, the understanding, the ability to do that for themselves. There are some adults who don't have capacity to be able to consent. They might be people with learning disabilities or cognitive impairments, so dementia, for example, or like a physical health problems, things like cerebral palsy, where they can't communicate a decision. And for those adults, then that's when they don't have capacity to give consent, and therefore need either involvement of carers or family to work out what is in their best interests. Now, specifically relating to under 18s, okay. Now, if you look at 16 and 17-year-olds, in English law, essentially, we assume 16 and 17-year-olds to have capacity to consent. They're competent, essentially. Now, when young people are under 16 years of age, that is when we refer to Gillick competence. So, for example, some of you who I'm talking to on the webinar might be 14 or 15. And if a doctor were to propose perhaps surgery for an appendicitis, an infection of your appendix, and you need to have that appendix removed to avoid overwhelming infection, you would be able to understand the risks of surgery, the benefits of surgery. You would understand why it's important. You'd be able to weigh up what are the risks and benefits, and you'd be able to basically provide a decision over it. You'd be able to say, yes, I want to have the surgery. Now, if a young person has the maturity and the understanding of the risks and benefits and consequences of an intervention, and a health professional doctor is satisfied that they are mature enough, they can consent to a treatment or an intervention. Now, in the instance where they don't have the maturity, or don't have the level of understanding, so perhaps a 5-year-old would not be able to consent to surgery, would they? Because they don't have the understanding. Health beliefs through childhood are very, at that sort of age, they start to think that medicine is like magic and a lot of things are magical. So a 5-year-old couldn't possibly consent to surgery. They wouldn't have the understanding behind it. So if they aren't Gillick competent, then you can go to their parents, or the individuals have parental responsibility for that child to consent to an intervention that is in the best interests of the child. Now, if a child under 16 years of age, they can consent to a treatment if they're Gillick competent. But children, technically, young people under 16, technically cannot refuse a treatment. Now, if they do refuse a treatment, then obviously you would discuss it with the child, you would discuss it with the parents, and the parents could consent to that intervention, provided it is in the best interest for that child who is refusing it. Now, there are some rare cases where a child might want a particular type of intervention, but the parents want a different type of intervention, which actually isn't as much in the best interest of the child. And it's cases like this where you may need to involve either a child protection advocate or qualified doctor, or an independent advocate. This is really important to make sure, because as the health professional, you are working in the best interest of the child, and parents, provided they are agreeing with what's in the best interest of the child according to the medical professionals, that's all okay. If the parents don't agree with it, that's when you may need to go to the court of law to come to a decision about what's in the best interest of that child. Um, I've never come across any cases like that. I understand them to be rare, because most parents want the best for their child and they will be guided by their health professionals. But it is important to raise it if there are issues that arise. So I've talked about Gillick competence, which refers specifically to consent in young people. Now, if we go back to the case about contraception for a 13-year-old, now 13 years old is really the borderline age. Children, specifically girls from 13 to 16, although technically it is against the law for that age group to have sexual intercourse, the legal age is 16. It is widely acknowledged that if children that age are in a relationship with someone of a very similar age, so, 13, 14, 15, then it is their choice and there will be no prosecution against either individual, provided, of course, there is no sexual abuse or nothing like that involved in the case, basically. Now, so in this case, if that girl, if Rachel was 12 in the case, that a 12-year-old is not considered to be able to consent to sexual intercourse and not have the maturity or the understanding. And therefore, if a 12-year-old were to come to you, that would be a different story. And you'd actually, perhaps might want to it might be something you'd want to discuss with another GP partner, to think about what safety netting you need to put in place for that young person. However, somebody who's 13, this Rachel has the maturity. She doesn't want to have a family yet. She feels contraception is in her best interests moving forward. So actually, what we're referring to specifically in the case of contraception is the Fraser Guidelines. So this is a lot like Gillick competence, but specifically relates to contraception. Okay, so the Fraser Guidelines specifically say that children from 13 to 16 must understand the advice from the health professional. The health professional must try and persuade the young person to discuss it with their parents, but a health professional should not break confidentiality if that young person is considered to be Gillick competent and Fraser competent, essentially. So, Rachel could say, I don't want you to discuss this with my parents. And if you think she has the maturity to understand what she's dealing with, then you have to abide by that request. And you should not go behind her back and tell her parents. You would, and if for any reason you felt like as a professional you had to break that confidentiality and tell her parents because her safety was at risk, for example, then you have to tell the patient that you're going to break that confidentiality. It's all about doctor and patient trust. It's what the entirety of healthcare relies on. It's what being a professional as a doctor is about. It's about being open and honest with your patient. It's about keeping confidentiality. When I say confidentiality, I mean you are keeping that patient's information to the limits of their medical care. So obviously you will write that information in their notes, you will be aware of that information, but you're not going to divulge or disseminate that information to anybody that is not directly related in that patient's caregiving service. So may include parents in this case. Okay, so sorry, going back to the Fraser Guidelines. So the young person has to understand the advice. You can't persuade them to tell their parents. You know that they will continue to have sexual intercourse regardless of whether contraception is prescribed or not. And therefore, if you were not to give contraception in a case like this, it may cause burden to their physical and mental health. Pregnancy in very young girls and young women in itself brings brings risks. So that's a factor. And then the final thing is that essentially prescribing the contraceptive is in the best interest of the young person. So those are all of the Fraser guidelines which specifically relate to contraception. Now, I think it's important to say that on the GMC website, and GMC will tell you that you, as a doctor, can conscientiously object. So, if, for example, as a general practitioner, you might be put in a position where a young girl comes into your room and asks for an abortion. Now, based on your own religious or cultural backgrounds, you might not feel able to proceed with that abortion. However, what is your requirement as a doctor is to be non-prejudiced in your approach, explain why you aren't able to perform an abortion, but then refer them to a clinician who will be able to perform that abortion for them. Abortion is offered on the NHS, and it would simply be a conscientious objection if you didn't feel able to do it because of your personal and cultural reasons. So I think it is important that the GMC recognise that. But obviously, with all our patients, there's you must never be prejudiced in your approach. Um, so so I think that's everything from my side I wanted to cover about ethics. Now, each week we're going to cover an ethical case, and I hope each week will start to build up on your experience of medical ethics. Now, obviously, you need to know about the 4 pillars of medical ethics, which you need to be able to quote in your interviews. So it's beneficence, so do good. It's non-maleficence, so do no harm. It's justice, so making sure equal rights, treating all patients the same. It's about treating patients according to the law, and then it's autonomy. So it's the fact that we are all individuals. We have our human rights that we're entitled to, and patients have equally those rights and that right to choose what is in their best interest when it comes to medical practice. So you need to be able to quote those 4 principles of medical ethics and discuss them in case scenarios in your interview. And I hope that by giving you a different case every week, it will start to make you think about ethics in clinical practice. Consent. So tonight I've spoken about consent in young people. Consent in adults without capacity, for example, is a whole nother talk and another time, and we will cover that in a later seminar. There's actually a lot of information for each case, so that's something we will come back to. Now, I have finished for my section of the medical webinar. The next stages are for the dentistry and the veterinary components of the webinar. Now, just before I go, I'm just going to have a quick look. If there's any questions, I'm just looking for questions at the minute. Uh, uh, oh yeah, Dr. Offal will give you a much better um, idea about medications and CYP pathology. Okay, no, that's fine. I think we've covered all of the questions. So I'm going to log off now, but make sure you stay on and rejoin for Dr. Uppal, who's going to come next with her dentistry seminar. Thank you very much for joining, and take care. Thank you.